It's good to see you.
Good morning, Cheryl.
Well, I tell you what, we had a lovely time when you came and visited us here at River. The interns just couldn't stop talking about how much information they gained, the confidence that you instilled with them in order to be able to do TFAST and AFAST, and how excited they were to be able to put this technology at work for the benefit of their patients. We really, really appreciated that information, and we especially appreciate the fact that you're willing to join us today for a few minutes to go over some cases that they found after you left and to answer some questions that they might have. So again, welcome and thank you so much for joining us.
Well, thank you so much for inviting me. It was my pleasure to be invited to your practice to train everybody.
All right, so I think we've sent you a couple of cases.
Yeah, so I will attempt to bring those up right now so we can look at some ultrasound images. Let's see if we can find this here. So I will screen share those with you now.
Thank you.
And we are going to start with scuttles, right?
That sounds good.
Yes.
So it's Andrew that was on this case.
Yep, that's me over here.
And Andrew, just tell me how you do a TFAST exams while I'm looking at this image. Like, what points are you using?
Well, you more or less make a V-shaped line using the apex of the elbow as the base of the V. You're going through about every other rib space caudally to that, extending dorsally. I could try and give more specific markers, but I think that gives an idea.
So typically when we do the TFAST, we do the two pericardial views in the ventral abdomen, and then the two chest tube sites, which would be where the kappa air would rise for pneumothorax, and then we have the DH view. So it's a 5-point scan. When we do the vet blue, that's when you go ahead and extend from the chest tube site and do that line towards the elbow and get the parahilar, middle, and cranial lung regions. So when I look at this view, it looks like you might be at a pericardial view. Of course, I can't tell if you're on the left or right side by this.
Most of it's left side, if I remember correctly.
So, certainly there is an object in the center of the screen here that looks like a piece of liver, and it could either be liver or it could be atelectic lung or diseased lung that's infiltrated or consolidated. So that's what I see here. I would have a tendency to think that this is probably lung, only because it has white areas in it that may or may not be air. If it shadowed through the far field, then I'd say that definitely is air. And certainly we wouldn't expect air to go through liver or be in liver unless there was an abscess, for instance. So when I look at this image, that's probably as much as I can tell at this view. Do you have any questions about this view?
No specific questions about this view. I think the specific question on this case was, as we went through the TFAST and vet blue process, we were never able to fully determine whether or not the diaphragm was intact.
I see. So if I look at this view, let's just look through all these together and then we'll answer that question, so make sure I do. But if I look at this view, this looks like a pericardial view too. And if I wanted to critique this view as far as what you're seeing here, your depth, what is your depth setting on this?
I think in this cat we had it at about 6 centimeters.
Yes, and you can clearly see it on the screen, right? So it's not a trick question. See it?
Yes, yes.
So one of the tenets for evaluating for pleural effusion and pericardial effusion is always increase your depth so you can see the heart in its entirety. See how I can't see the heart globally?
Right.
So I would definitely increase my depth. This structure right here where my mouse is, do you know what that structure is?
Let's see.
This little line.
Yeah, nope, I don't, honestly.
So this is actually a normal ligament that attaches the heart to the diaphragm. So you'll see that when there's pleural effusion, and that's actually a normal anatomical structure. It looks a little thick, but that's the, I don't know if it's called the pericardial phrenic ligament, But that's what that is right there, where that little line that's gray that goes from the heart to the diaphragm there.
Very cool.
So here I can just see that there's pleural effusion. So let's go to the next clip. So the critique on that would be increase your depth. Get as far away from everything that you're looking at as you can so you can better interpret what is heart, because heart's the fluid-filled structure in the chest that you don't want to stick a needle into. Mm-hmm. Because that wouldn't be very good for your patient, right?
Right.
So I'm right back to this again, and I see the same area that you were concerned about, I would imagine. Is that atelectic lung or is that liver? And I can't tell still. So I'm going to go to the fourth image that you sent me. And here you're a little bit better as far as getting the heart globally, but I still would increase my depth so I get a better image there and see if I can clarify the anatomy better. This is air-filled lung that keeps floating back and forth where my mouse is now. Can you see my mouse when I move it?
Yes.
And I can see the heart more globally. So your landmark to know if you're seeing the heart globally is certainly you can appreciate the chambers, but also to look for the bright pericardium in the far field, because usually it's the brightest line. So it's at the very edge or margin of this clip that you've sent me. So I think that actually takes care of all the clips. So if I was going to critique this, if you're doing a T-fast, and I'm not sure if you're doing it exactly the way that we teach it, do your 2 pericardial views, do your 2 chest tube sites, and do the DH view. And if I was concerned about a diaphragmatic hernia, which of those views do you think is going to be important to evaluate the integrity of the diaphragm?
Most likely the DH view.
That's right. So when you do the DH view, if you do it the same way every time and fan through it, you can get an idea if there's any break in the continuity of the diaphragm when you fan through there. And we're not radiologists, but that would be one way where you could evaluate to see if there's any break in that expected continuity of the diaphragm when you fan through. You know, usually to me on the DH view it looks like an arch that goes through the screen if you orient the head to the left and the tail to the right of the screen. The other thing about the DH view, when you start the view, how do you usually start it? How we teach it? What's your starting point?
So go just caudal to the xiphoid process.
Yes.
And sorry, I don't know exactly what kind of answer you're looking for there.
Let me get back so I can actually see you. So when you do the starting point, we start with the gallbladder kissing the diaphragm.
Yeah, okay.
And in dogs, that's really reliable. So you can almost always get the gallbladder to kiss the diaphragm or touch that bright white line that shows the diaphragm. And if you do that every time, you can use that as a marker well as the gallbladder in the right place. Because usually with the diaphragmatic hernia, right, the liver goes up into the thorax. So if I can't find the gallbladder where I expect it to be, that would be another clue that maybe there is a diaphragmatic hernia that's present. So you can look at continuity as you fan through it with that line that you expect with the diaphragm, and you could also see, is the gallbladder there where I expect it to be? Certainly, if you have things in the thorax like hamburgers and highways, right, loops of small bowel, well, they should never be near the heart. So those help you if those, if those organs are herniated into the chest. But if it's liver, it could be difficult to tell between liver and atelectic lung when you're on your pericardial views.
Right.
So this one did end up being a diaphragmatic hernia?
No, it didn't. On this particular case, we removed the pericardial fluid and still had the same question afterwards as far as whether it's atelectic lung versus liver. We went off to do an echo in this cat just to rule out any possibility of heart disease going along with it if there were a diaphragmatic hernia. And during the echo, the cardiologist found a mass that looked like either on or right next to the right ventricle of the heart. So this actually turned out to be on an evaluation of the fluid, cytology of the fluid, turned out to be a carcinoma.
I see. So in hindsight, knowing that information, then with Scuttles that you were looking at atelectic lung.
Right.
So let's see if we can look at these radiographs. Could you tell from the radiographs, or did you get a better idea, or was it too hard to tell?
Yeah, so in the radiographs, there was, of course, the fluid kind of obscuring interpretation, but in the left caudal lung lobe, it looked like there was, soft tissue opacity. Again, didn't quite help us to differentiate liver from atelectic lung, just because there was so much going on in that area. And we actually sent off these radiographs for evaluation by a radiologist, and they had the same questions and concerns.
Yes, because it does look like you might have, you can see my screen now, right?
Yes,
Correct.
sir.
So with this radiograph, it does kind of look suspicious that is there something abnormal along the diaphragmatic line here, but the stomach is in the correct position, or at least it looks like it's in the abdomen. But now you have an idea of what atelectic lung looks like, and it can look a lot like liver. And when we do our 5 basic lung ultrasound signs, that's why we call it the tissue sign, because it can look a lot like liver. Is there anything else that you wanted to talk about with this radiograph or this case?
I have a question.
Mm-hmm.
Can you hear me?
Yes,
Yep.
I can.
Sue, I have a question. The term hepatization of lung,
Yes.
does that refer simply to the lung tissue looking like liver?
Yes. And when we went through the 5 basic lung ultrasound signs, I'm just looking at these radiographs still. It does look it would be difficult to tell is that a diaphragmatic hernia or not. But certainly the cytology is really helpful, and that's the strength of ultrasound. Hey, if we can do get cytology on this, that's going to be helpful, and it might be a moot point. Are you seeing me now?
I am.
On the screen?
Yes.
So your question was hepatization of lung, and when we did the 5 basic lung ultrasound signs, we did dry lung, which is a glide and A lines. We did ultrasound lung rockets, which are B lines. And then instead of saying C lines and PLAP lines, which gets really confusing, we decided we go with a shred sign for consolidated lung with aeration, a tissue sign, which is consolidation with no aeration, and then we went with nodule sign. And instead of calling the tissue sign the liver sign, which would be really confusing, we used tissue sign. And we actually borrowed that terminology or modified it from Lichtenstein's.
Okay.
Now, he uses those terms too, but what's problematic is when they did the lung ultrasound consensus statement in intensive care medicine in 2012, they went with A lines, B lines, C lines, and PLAP lines. And A lines make sense because A and air go together. But I still don't know why they came up with B lines other than it follows in the alphabet. C lines, you might think, are consolidation because C and consolidation start with the same letter, but consolidation aren't lines at all. So the visual is a lot better to go dry lung, wet lung, which are lung rockets, shred sign, tissue sign, and nodule sign. I think that's a better language for us to communicate with.
Thank you.
You're welcome.
All right.
You gotta love consensus statements, right?
Yeah, absolutely. Keep us all on the same page, right? All right.
Well, I wish they would have named them a little bit more practically like they did with Lichtenstein's suggestion. You can pull papers in 2015, and you'll see authors talk about the shred sign in those documents where they ignore the consensus statement just because it's so hard to communicate with the A line, B line, C line, and PLAP lines.
All right.
So that was a good case. That one's a challenge to figure out.
Yeah, and thanks
But
so
then
much for
again, in-house with cytology, you might have been able to pick up carcinoma or have a really good idea if you did your own cytology on that. I've always been taught that if you have 8 or more cells that are clumped together, especially if they're in 16, that they're 16 or more cells clumped together that look like they could be mesothelial cells or carcinoma. The mesothelial cells don't clump that much. So I don't know if you ever knew that rule of thumb or not, but that's how I was trained.
Fair enough.
Yep.
Any questions, anybody? Okay, Linus, I think, is up next.
So Linus, so that's Dr. Erickson's, Tim's case.
Yep.
Do you want me to just pull up? Hi, Tim. How are you?
Good.
Good. Do you want me to just pull up those images?
Sure.
Okay. Hopefully, I won't disconnect us. So we are on Linus. So Tim, going back to your TFAST, Is that the way, I mean, not Tim, Andrew, is that the way you're doing a T-Fast, or are you blending it all together with a vet blue?
Honestly, in the kind of more emergency situation where we just want to get a quick idea of how the lungs are looking, if we're finding fluid, we're kind of combining it together.
All right. So I would try to, it depends on the routine that you have, but I would try to, at least in my mind, if I do the two ventral views, then I get used to what heart should always look like at those views.
Hmm.
And if I do the chest tube site and then go to a vet blue, then I get a better idea of where all the anatomy is and expected. So that might help, it might not. I don't go through every intercostal space like a radiologist would. I
Right.
just want to have a quick view of what everything's like. But the DH view would have been really helpful on that cat also. If you just fan through there, and you might have had that view too, but that would have been really important for knowing whether or not that might have been helpful for the ruling in or ruling out of a diaphragmatic hernia.
Oh yeah, absolutely. And we did end up doing that view. I just think unfortunately we didn't take a video of it, and it was
I
still
see.
weren't able to get the entire diaphragm fanned for whatever reason. So there was still a question left behind.
We're still
Could you see was the DH view helpful for knowing whether or not there was a diaphragmatic hernia, or was that also difficult to interpret?
It was still difficult to interpret. We're getting some artifacting at the level of that the kind of atelectic lung / liver issue. There was just some artifacting that made it difficult to interpret.
Because what happens at the DH view when you don't have air right up against the soft tissue of the diaphragm, then you don't get that bright white line. So when there's pleural effusion there, it's a lot harder to potentially follow the diaphragm because you don't have an air tissue interface. You have a air fluid or fluid soft tissue interface
Right.
because the lung has moved away from the diaphragm. Now the other thing you could have done in that case, and I know I have a video clip in now, is after you tap that, if that was pressure atelectasis of the lung, then it might have filled back up with air in time. And if it was, a neoplastic process and it's that consolidated or infiltrated, then obviously it's going to keep looking like tissue. But just think, when you have a lot of pleural effusion, you have pressure atelectasis of lung, so you might not be able to sort that out. But after you take off all that pleural effusion and you recheck your case, then you can always see, does it have normal aerated lung, or just some lung rockets, or is it still really ugly lung that looks consolidated? See the
Right.
thought process there?
Yeah, yeah. No, I'll keep
The
that in mind.
serial exam would be helpful too, as far as going that route. So could you see, can you see Hartley's uh, image now that
yes.
I'm playing? Okay.
Yep.
So on here, where are you, Tim, as far as the probe?
The probe's in the left side of the thorax, and we were leave a couple rib spaces caudal to the heart.
Okay. So I'm going to take that one down, and we'll go to the next one. So I don't know if you all are doing the T-Fast exactly as how I have taught it as far as using those points. Certainly you can search around too. It's harder for me to tell you where you are if you're searching around. But certainly sliding the probe is appropriate after you do the T-Fast. I would prefer just to see the standardized images first and then your look around afterwards. These all look the same to me, which is just that this area here of soft tissue, which I can't tell what that is. And I don't know if that's a ligament, I don't know if that's fibrin, it's hard to tell there. And you can't tell with ultrasound. But you do have fluid there to sample, which is what ultrasound strength is, so that's the power of the study too. Seeing where this clip is going to come up. Are these clips pretty similar, or do you have something?
There are different views.
So when I convert this one, I'm just having a hard time getting it to come up on my screen. Are you still there?
Yeah, we're there.
Ah, here it comes. So, Andrew, you're still there, aren't you?
I am still here.
So, if you saw this image that Tim sent me, and you were looking over his shoulder, and he was saying, what do you think of this image? How would you critique this one, going along the same lines of what I had told you?
I would say increase the depth.
That's right. Because I can't see the heart globally, and it's really important to see it globally so you can sort out things. So I would increase your depth even more. I think this is left ventricle here, and this is probably right ventricle there, the mushroom, and then the man in the moon and the cow jumping over the moon, that cap that goes over the right ventricle, but it's a little obliqued also. Certainly there's pleural effusion there. And you can even get fat around the heart. I'm not a radiologist, but I don't know what the soft tissue is that's a little bit brighter. It could be atelectic lung too, so it's going to be hard to figure all that out and sort that out. Let me see if I can get back to those images again. So far on that study, the best I can tell you is that we're just seeing a lot of fluid, right? And it's hard to sort out the other things, but I can see the heart, most of the heart there, and it certainly isn't pericardial effusion. It looks like it's all pleural effusion.
While Dr. Lisciandro is looking up these things that he's going to bring up next, I guess one of the things we should all learn is that we need to start following something a little bit more systematically. You know, doing our TFAST very systematically as he has taught us to do, where we do the 2 heart windows, and then we do 2 chest tubes, and then we go through the vet blue. And I think that's probably something that I'm equally guilty of. Oh, let me take a look around, you know, look really quick. And perhaps we should make a commitment to do things a little bit more systematically, and it might help us in the future.
I think it'll help you learn a lot quicker too, because it's like doing a physical exam and doing it in a standardized approach every time the same way. Do you have the goal-directed templates?
The goal-directed templates?
Yeah. Do you record your views and your records, or are you just freehand typing those in, or how are you doing? How do you record your TFAST?
We freehand.
So I'm going to send you new templates on that.
Oh, cool.
All right, that will direct you. So make sure that you get those new templates, and then you can modify them, but those will help you stay on task.
Oh, that's awesome. I love that idea.
So I'm still screen sharing, so you can see, you're looking at your own image right now?
Yes, I'm looking at me.
Okay. So with that case on Linus, do you have any other questions with regards to that, or anything else you want me to comment on as far as images go? I don't know if I can pull up the radiographs on Linus. What's Linus's last name?
Partly.
That looks like him, right?
Oh, here's Linus here.
Yeah.
So if you see Linus here, you can see that everything's pretty compartmentalized in the front of the chest.
Mm-hmm.
But it's hard for me to orient myself on those images. If the marker's always towards the head of the patient, and that's why I like to do the marker towards the head of the patient and not do it like a cardiologist would image the heart, because then I know to the left of the screen is always towards the head, and to the right is always towards the tail. So I don't know if you recall, but when we did our echo images during the course, I do everything backwards from the way a cardiologist would do it. But it always keeps the head to the left and the tail to the right. So if I'm imaging the heart and I see something to the left, then I know on my radiograph that the lesion is in front of the heart too. Does that make sense?
Yes.
So when I look at this view, let's see if I can, I'm not sure if I can get through these other views. We saw that fluid there, so it was very compartmentalized. I just can't get that from your study. But I think if you did a left pericardial view and save that, did your right pericardial view, save that, did your DH view, save that, then I would know at the DH view, hey, there's no fluid there. And then when I went to my chest tube site, I probably would have seen dry lungs in this case.
Mm-hmm.
So if you look here where my mouse is, that would be my pericardial view. I do it on both sides of the chest. But when I put my probe here where my mouse is at the DH view, I might not have seen any of that pleural effusion, and that would have really helped me know that that was compartmentalized.
Okay.
And when I went up here to do my chest tube site, I probably would have seen really dry lung, right?
Right.
Does that make sense?
Yep.
So if you gave me those images in that way, I would have been able to interpret that study a lot better. And if you went back to that study too, you might have been able to figure it out a lot better too by having that approach. So that covers the second case.
Yes.
And that was really good. So I really am enjoying this actually, because
Fun.
there's a lot of ways I can help you out with better performing these studies and giving you pointers so you get a lot better at them. And I hope that you go, you know what, if we do it the way that Greg just said and do the 5-point view and then look around afterwards, then we have a lot better information, and I think you can figure out things a lot better too.
Great.
So our last case, I just don't know if I have Peanut's radiographs, and I'd like to show them and go through those too, because he's the most, or she is the most interesting case, and that her lungs are clear and she has all those rockets.
Yeah. She does have some interstitial pattern in her lungs, but not to the degree that you would expect from the rockets that you're seeing.
Absolutely. So I'm going to try to get her study and not disconnect anything here.
Okay.
So our last case is Peanut, a 6-year-old female spay diagnosed with pulmonary hypertension.
July.
In July. So you said 9 months ago?
No, 9 months was her prognosis.
9 months was her prognosis.
Yeah, she had.
So July,
yeah,
August,
yeah,
September, October, November. So she's been at 4 months.
Yeah, she's about halfway through her prognosis and had been doing well on sildenafil only.
And this is a radiologist that did the study?
No, actually, Dr. Greg did the study here.
She did the study there.
Yes. The initial study, the hypertension diagnosis.
Okay. So I'm getting there to my screen share.
Great.
I think I am. You can still see me, right?
I can still see you.
All right, here we go. So the thing that's so powerful about lung ultrasound.
Okay, this is little Peanut.
Yep, that's my talking.
Can you see how he's breathing there?
Now if we can just see where Peanut pops up here on my screen. That's the hardest thing to get up here. So I'm not sure why it hides it somewhere on my Mac, and I'm not sure where, when I play it, where it just went.
Well, that's the beautiful thing about, there we go, I see her.
Okay, this is little Peanut. Relax, Peanut. You know, can you see how he's breathing there?
So I can already see you did your study because you have a little bit of contact medium on the patient.
Mm-hmm.
And the thing that's so powerful about lung ultrasound is they have abdominal breathing and nostril flaring, but you have no idea what's wrong with your patient. And if I put a stethoscope on Peanut too, I have no idea what's wrong with my patient with the stethoscope because it's so insensitive. But if I go ahead and do lung ultrasound, it gives me a lot better idea. So let's go through these images. You're still there?
Yep, we're here and I can see them.
So if you look at this image, can anybody critique this for me that's in there in the audience?
Okay, guys, what do you see?
So if you don't know, I'll ask you questions. So does anybody go, you know what, this image could be a lot better, and I can tell you why right now, Greg, and I'll volunteer and tell you. Is anybody that confident enough looking at this to tell me how this could be a lot better image?
I'll take a stab at it, and we can edit it out.
About the depth.
But the depth, I think we need to be closer so we get that classic alligator eye view.
Yeah, so what should your depth be with lung ultrasound?
Around 2 to 4 centimeters.
It should be 4 to 6.
Oh, 4 to 6.
So I'd say somewhere between 4 to 6. If you get in too close, then it's just too hard to see things. And if you're too far away, like you said, it's really hard to see the lung line here. So you want to go 4 to 6 centimeters, and to make the image really good too, you put the focus cursor straight across from the lung line. So see, there's 2 focus cursors here.
Mm-hmm.
You could make that down to 1,
Mm-hmm.
and then I would put it straight across from the lung line.
Okay.
The other thing is when I put my mouse here, what is right off my mouse?
Where's your mouse? Oh, that's interesting.
What is that bright white line?
That's interesting. I'm not sure what that is.
So what's the orientation of this image? The head should always be to the left and the tail should be to the right. Where's the orientation marker? The screen marker.
Oh, it's on the right-hand side.
Yeah, so what do you think this is?
Probably in the caudal part of the abdomen.
Yeah, so that's probably stomach with a little bit of liver on top of it, but I can't tell because you're too far away.
Yeah.
But you should always have the head to the left and the tail to the right, and if you adhere to that, even when you're imaging the heart, you will have a better idea where the problem is, because the head's always to the left and the tail's to the right. So you need to increase the depth on this to 4 to 6 centimeters, and your lung ultrasound will get so much better. Move the focus cursor to straight across from the lung line, and make sure that the head's to the left and the tail's to the right, because you'll misinterpret this as being a step sign, pleural effusion, a shred sign, a tissue sign, because you are not sure, you don't have the orientation where the head's to the left and the tail's to the right. Because when we look at lung, we ask the question, is it wet or dry? And then we ask, is there anything off the lung line, which would be a shred, tissue, or nodule sign? And then we ask ourselves, can it be a pitfall of lung ultrasound, abdominal contents that are coming in and I'm misinterpreting them? And if I have the head to the left here and the tail to the right, then I'm always thinking if something's coming in from this side where I'm swinging my mouse cursor, is that liver, stomach, or gallbladder? Does that make sense?
Yep, totally.
So we're going to go to the next image. So there I see a lot of lung rockets.
Yes.
And here, of course, we can make this a lot better. Here I see a lot of lung rockets, which are also called B-lines.
Yep.
So let's go to 3. So now, if you did this in a systematic way, we always teach to go caudal dorsal. We always start on the left side. And you go caudal dorsal, parahilar, middle, and cranial. Then you hit a blank clip, so I know you went to the right side. And then you go caudal dorsal, parahilar, middle, and cranial. Jessica Ward, who's part of the cardiology department, she's a boarded cardiologist out of North Carolina State. In our study, she and I reviewed 800 images. She didn't label a single image in that study that we presented at ACVIM because she always went the same way. You go left to right, and that's how we've always been doing it at our practice, and that way we don't need to label anything, and we can go back and review the study, and we know exactly where you are in the vet blue, because you go caudal dorsal to parahilar to middle to cranial. So here again, you're just out so far. You can clearly see that there's lung rockets or B-lines everywhere, but you're over 1, 2, 3, 4, 5, like 6 intercostal spaces.
Sure.
And the reason why, that's not a bad thing per se, because you could say, wow, I got a lot of lung in this image. But the problem is I can't tell if there's anything coming off the lung line because you're so far away from it. So your question was, are those B-lines fibrosis or not? And if you were 4 to 6 centimeters, I could probably answer that question because I could look to see if this pleural line, this lung line, was thickened.
Sure.
I think, though, that this is all edema, and that's why I think this is such an interesting study, because I would treat this case with Lasix for sure. And I would probably be somewhat aggressive, at least go every 6 to 8 hours. I wouldn't go every hour and do that protocol. But I would give it a good dose of Lasix, like 2 mg per kg every 6 to 8 hours, and then I would do another vet blue on it and see if those go away.
Can we look at her radiographs?
Yeah, so I'm trying to get there.
And I did originally give her a 3 mg per kg dose of Lasix when she first came in.
Because they should go away pretty quickly when you look at that radiograph, because you go, gosh, there's rockets everywhere, but there's not a whole lot on the radiographs. And lung ultrasound is so sensitive that you'll pick up edema that you'd otherwise not see on a radiograph or hear with your stethoscope. To continue on, though, going to peanut, there's some really important things that you need to do. So I'm gonna send you templates because you're not you all aren't disciplined enough in doing this the way you're doing it right now. And if you go the 2 pericardial views, the chest tube sites, and the DH view, and save them that way, and that's why this would be good to do in another 30 days or so, potentially, you gain so much more information. When you do the TFAST echo views, what views are you doing? So whoever wants to volunteer to answer that question.
All right, guys, answer up.
Usually, I do it on the with them in right lateral, go on the right chest, right side of the chest, and start with trying to get the mushroom view, the fish mouth, and then switching and trying to get the 4-chamber view.
Great. So when we taught the course before, you can see me now, right?
Yes.
Okay. We have a mushroom view. And if we go above that mushroom, if these are the papillary muscles, then you start to see the windshield wipers, right? The mitral valves. And then they fish mouth across, and then just above that, you'll pop up and see the Mercedes-Benz sign and the teardrop of the left atrium. And then as you come back down, they mushroom, and then you're in the windshield wipers, and then you're back to the mushroom. If you go down too low, then the mushroom looks really goofy, and then you come down a little gray circle. And when you're looking for pericardial effusion, you're going to go too low and below the mushroom because you want to always move away from heart chambers to look for pericardial effusion. So you always image towards the muscular apex of the heart. You can do that automatically through the DH view because when you angle the probe that way, that you're right there on the muscular apex of the heart. And when you go down the ladder, you're on the muscular apex of the heart too. The reason why I explain that, though, is because it's easy to get too low on the heart and then you make mistakes on volume status because you think they have poor volume status and you're just too low in the heart. But if you remember that the contractility and filling is just below these valves. So if I move up and I get valves and go right below them, move up, there's valves and go right below them, I know I'm in the right place, and that's where you drop your MO cursor to get your MO measurements is just below these valves, the windshield wipers. So in this case, you're concerned about pulmonary hypertension. So when you're doing your TFAST, you should have been showing me your echo views.
Okay. Fair
And
enough.
if you look at your echo views, what's the most important echo view to view on peanut to see if peanut has pulmonary hypertension?
It's going to be the base of the heart. Right at the base of the heart view where you've got your aorta, you've got your left atrium, and over here you've got your pulmonary artery and your valve.
Okay.
Or you can do a 4-chamber.
Okay.
Right?
And what are you going to look at on the 4-chamber?
The size of the right ventricle and atrium.
That's right. And so for this study, when you said, well, is this pulmonary hypertension or not, and you wanted to get an idea of that, that's the view you should have sent me, right?
Yeah.
So if you want to
Doppler maybe.
give me the information. So when you do walk up the ladder, because that RV to LV ratio is really important, it will be on the template to make you look at it.
Okay.
But as you go up and you see the windshield wipers and then you get the fish mouth, either way where you see valves, that's where you're going to rotate your probe and get your long axis 4-chamber view.
Sure.
And if you show me a huge right ventricle and a huge left ventricle, then I know that that dog has pulmonary hypertension.
Fair
But
enough.
my working diagnosis with the images that you sent me is that that dog has cardiogenic pulmonary edema and has pulmonary hypertension, and it should be Lasix responsive.
Okay.
4 hours later, you could have put a probe on that and done your vet blue.
Mm-hmm.
And on your vet blue, you could have counted lung rockets again and seen if those infinity were starting to split out or even go to just a few lung rockets, and that's a really sensitive way to monitor them for response to therapy. So my working diagnosis on that would be that it's not pulmonary fibrosis, even though pulmonary fibrosis can give you B lines or lung rockets, that's cardiogenic pulmonary edema till proven otherwise, should be Lasix responsive, triple therapy, it's probably related to the pulmonary hypertension, but that would be the way that I would look at it in ultrasound. I can answer all those questions in just a few minutes if I do a standardized TFAST vet blue on that case. The other thing you can look for if you think that the right heart is failing is what? When you do a TFAST. What do you always look at for volume status? It's your new central venous pressure.
The DH view and the vena cava going through the
Exactly, right? And the vena cava is characterized as being flat with no volume, This is normal, right? About a 50% bounce. And if you see a bounce, you're in the ballpark. And when it's fat with those big tree trunks, right, because of hepatic venous distension, then that is really helpful too. And anytime you have a heart failure patient, you know, you can go up the ladder and look at the LA to AO ratio, and you can also put that together with vet blue, because if you have a big left atrium and you have wet lungs everywhere, then you have left-sided congestive heart failure to proven otherwise. But don't fail to look at the caudal vena cava, because then you can get an idea, do they have left and right-sided heart failure, or is it just left-sided? So, and that's so easy for you to image. You're right there. Pay attention as you fan through that caudal vena cava. So it would be great to do this in 30 days, send you some new templates, and everybody have a powwow and say, we have to do it this way. And if you sent me studies that way, you could be stars in 30 days on this.
All right, I like that. Let's do that, okay, guys?
All right.
Do this. Thank you so much, Greg. You've been so helpful, reminding us there's the protocols for a reason, reminding us that we do things in a stepwise fashion. We get far more information. And thank you so much for your time.
Well, you're welcome.
And we will keep you up on that offer to come back in 30 days, maybe 6 weeks, and kind of review our technique and see if we're doing a better job.
I would be glad to do that.
Okay. Thanks so much.
One last thing, though, I wanted to have enough break, is when you do your vet blue, I could pull up a vet blue. How do you do a vet blue, Andrew? Tell me how, because you like to volunteer for everything. I like that. But tell me, how do you do vet blue?
Yet? Yeah, so the vet blue, I think, was more closely to what I was describing when we first started with the V shape with the apex of the elbow. Let's see, are you still there? I can't tell if you're moving or not. There we go.
Yep,
okay, but yeah, doing the V shape with the bottom of the V at the apex of the elbow, going for the not necessarily every other intercostal space, but we're going for 4 main spots, going with the dorsocaudal lung field, a bit more ventral and cranial to that, then at the apex of the elbow, and then a bit more cranial and dorsal from there.
Yeah, so let me see if I can share my screen and show you how to do a vet blue on a quick video clip.
Cool.
I think I can pull that up. Let's see here. Because I'd like you to make sure that you're doing it the way that we had done in that course. Of course, we did a lot of things, so this is really cool to do a follow-up.
Yeah, it is, and we appreciate the refresher.
So I should be able to do this as long as I don't disconnect everybody. So that's the thing, is opening these windows. So I'm going to share my screen. So I'm almost there. I know your time is short. I'm sharing my screen. And can you see
Yes.
the dog?
Yes.
So this is the way we teach it, just to give you a refresher. Here's this dog, and it could be Peanut, and Peanut's standing up. You're going to go to the chest tube site. So I know this is busy, but I'm going to show you a video clip of how to do this too. But remember, we're going straight up along from the xiphoid to the chest tube site, and then a vet blue is parahilar, middle, and then cranial, and we have to slide that front leg a little bit forward to get to cranial.
Okay.
On this dog right here, what we're doing is we take our probe and we go up to the chest tube site, kind of where this little dark gray area is.
Yep.
Can you see my mouse?
Yes.
And the best way to do this is draw a line from where my mouse is at the chest tube site to the elbow. And go halfway to the elbow, that's parahilar, and then go to around the elbow with them standing or sternal, and that's your middle, and then slide up into the cranial area. Everybody follow me on that?
Yep.
I was in Canada. They said it's like a hockey stick. See the hockey stick?
Sure.
So I'm going to play this video clip. Let's see how this works.
Now perform the right side, that blue. Here again, our landmark is the xiphoid to the highest point on the chest where the cap of air would rise, where we're still over lung, and we can get the gator sign for proper lung orientation. We We move from the chest tube site, looking for the glide sign or ultrasound lung rockets to rule out pneumothorax. And then we move from the chest tube site, called the caudal dorsal lung lobe region, to the parahilar lung lobe region, to the middle lung lobe region. If we catch some heart here, we slide our probe above it, and then we slide up into the axillary region for the cranial lung lobe region. This will complete the right side of that blue. Again, it's like a check mark. So here we have the chest tube site, called the caudal dorsal lung lobe region, markers towards the head of our patient. Move to the parahilar lung lobe region, middle lung lobe region. If you catch some heart, you move up above it, and then we slide into the axillary region to complete the right side of that blue. The reason why we go from left to right is we have shallow settings, and now when I finish on the right side, I can feel for the apical beat of the heart. I can take my probe marker, put my probe towards the elbow, increase my depth on my ultrasound machine, and now I can do my right pericardial views of TFAST, where I go ahead and get the short axis mushroom view, walk up the ladder and back down the ladder, seeing the mitral valves, and then the fish mouth up to the aortic to left atrial view, back to the mitral valves, and then rotating my probe 90 degrees for my long axis four-chamber view. If I start with vet blue and then go to the cardiac views of TFAST, now I can lay the patient on its right side and finish the abdominal fast with only one setting change, from shallow to deep, going from vet blue to the heart sites, which will continue with the increased depth going through the remainder of AFAST, which will complete global fast, which is vet blue, TFAST, and AFAST all combined.
So that was a busy slide. That was a busy video clip. But, and also, they're not lung lobe regions. Are you still there?
Yes, we're here.
They're not lung lobe, you know, there's not a parahilar lung lobe, so I have to improve on that. And plus, then I showed you the cardiac views on the left side of the dog, and you're really on the right side of the dog.
Sure.
Everybody follow me there?
Yes.
But I think it's really important that what I would do is get in the habit of doing my chest tube site and drawing a line to the elbow, and halfway to the elbow is parahilar, and then right around the elbow is middle, and then slide forward to get your cranial, and then you'll hit your marks like on the radiograph here.
Okay.
And then make sure that you standardize looking at those cardiac views, because if you standardize those, then you can pick up pulmonary hypertension. And if we go ahead and show you that real quick, pulmonary hypertension is really easy to pick up. I've changed some of my artwork since the last time I had lectured to you. And the views of the heart are in here coming up. Is if you walk up and down the ladder of the heart, there you have your mushroom, you have your windshield wipers, you have your fish mouth, you have your Mercedes-Benz. And when you're in this region here, that's when you rotate the probe to get your four-chamber. Here's a dog with pulmonary hypertension or right-sided heart problems, and it's really easy to see that. This would be a more normal right ventricle. See how small it is? And there's your left ventricle, which is huge. And that's how they should be, 1 to 3 to 4. See the ratio here on the cartoon?
Mm-hmm.
If you look at this patient, you can see clearly that this right ventricle is huge. See that?
Mm-hmm.
And that would have been really helpful on Peanut to have that view.
Sure.
See that?
Sure.
And you'll pick that up really quickly with your eyes. And then, as Andrew said, always look at the caudal vena cava. Does it have a bounce? Is it fat or is it flat? And that really helps you too with right-sided heart problems. So on the templates, you'll have these 3 basic views: the mushroom view, going up the ladder to the LA to AO ratio, and then the 4-chamber view. I do this different than June Boone because I always have the marker to the left, so I know the head's always to the left. And I think that's a good idea for non-cardiologists, non-radiologists doing these formats. So that completes just a little quick review of the way to do those things. And I'm trying to figure out how to screen. Are you still there?
Yeah,
how
we're
to
still there.
Screen share off.
Oh, perfect.
So I'm back.
Thank you.
Am I back?
Yeah.
All right.
Great. All right, I'll be in contact, and we'll do a little bit better job. We'll get some systematic studies, and we'll come back and see what you think about the progress we're making.
All right, that was awesome. I
Oh,
really enjoyed that.
thank you so much.
All right, good luck, interns and residents, whoever's there. Good to see all your faces.
Good to see you too.
to
And
see you.
listen, have a great rest of your week, okay?
Yes, you too.
All right. Bye, everybody.
Take care.
Goodbye.